Great. Yeah, thank you for the opportunity to speak to everybody tonight. And I'm one of the vitreoretinal surgeons at the Gavin Herbert Eye Institute. I'm coming up on the end of my ninth year here, and I spend a lot of my time, well, 2 days a week, taking care of patients with retina-related conditions, whether they be medical or surgical conditions, and then the rest of my time trying to develop new technologies in my lab so that we can better understand the variety of diseases in the eye associated with the retina. And age-related macular degeneration is one of the flagship conditions, if not the flagship condition that the technologies at my lab tries to help to elucidate. So just going to dive right in. I like to keep things fairly simple and kind of relatable, and that is give you a sense of what a person's experience is with macular degeneration. So we all have a period in our life when we're having to read something. And here's an example of driving down the freeway, a familiar sight to those of us in Southern California. And so there are signs that one has to read on the freeway, like where to go to San Diego or where to go to Long Beach. And this is what a photograph taken by a camera. So this is a little bit different from human vision, and I'll get into that in a moment. So when we think about a camera, there are usually two lenses, like this blue and yellow lens over here, and then there's also the film in the camera, or a CCD or CMOS sensor, electronic sensor that can turn whatever is focused by the lenses onto the film or sensor and create an image. That's typically a negative image if it's film, as shown here. And this is a little bit different from the eye and similar in other ways. So the eye has a cornea and a lens inside. The lens inside is what turns into a cataract with age. And so that's what is replaced with cataract surgery. And so what we see here on inside the eye is the analog of the film in the camera or the sensor. This is the retina. And all the information focused by the cornea and the lens is focused onto the retina, and that's turned into a neurochemical signal. Each photon is turned into a neurochemical signal that is sent to the brain along the optic nerve. And it creates an image that looks like this right here. And so this is zooming in. And so as we know, we can see and we can read with our central vision, but it's harder to read and see with our peripheral vision. So our central vision is really good at seeing color and high acuity or small details. And our peripheral vision is really good at detecting motion and seeing dim features. So this is what we kind of consider our central vision, and this is what we consider our peripheral vision. And in the aging eye, the first thing that people typically notice, and I'm 46 years old, so I'm finding that my arms are getting shorter, and so my ability to focus light coming into the eye onto my retina is getting more challenging. So I'm developing a little bit of presbyopia, meaning that I'm going to need to start wearing reading glasses in the next 5 or 10 years to be able to see things that are close to my eyes. Um, Dryness of the surface of the eye is a very common condition, especially in Southern California, where we have very little humidity in the air. But dryness on the surface of the eye is typically treated with lubricating gels, lubricating ointments, and lubricating liquid tears, primarily liquid tears, and then also taking a fish oil or omega-3 oral supplement to try and produce more oils to cover the surface of the eye and prevent evaporation of the fluid on the surface of the eye. Cataracts I've already alluded to. This is where the lens becomes less clear with time. And then glaucoma is another condition where the optic nerve, the connection from the eye to the brain, slowly degenerates over time. And that's typically associated with peripheral vision loss. So I won't be talking about these conditions in detail today, but I just think they're important to understand in the context of the aging eye. I'll be focusing on age-related macular degeneration, which is a condition that affects the immediate posterior part of the eye, where light from the cornea and lens is focused to give us our high acuity vision. So coming back to the example of the freeway and driving down the center and driving and being able to read while driving, we think about our central vision in the context of macular degeneration. And a gradual decline in contrast sensitivity is what people typically notice. So if we reduce the contrast, we can see that it becomes harder and harder to read the letters in the sign. And this is what someone with macular degeneration might notice. Now, it's not typically that they'll notice this under bright light conditions, like during the middle of the day, like shown in this picture. It's typically when it gets to be dusk-like conditions, where there's less light to provide us the contrast that we benefit from being able to just see letters on a dark background or dark letters on a light background. So under low light conditions, you can see already that it's harder to read the San Diego letters than it is under bright light conditions. And so bright light conditions are really what people with macular degeneration need to be able to see at their peak performance. And we can see that even under bright light conditions, there can be some degeneration of the quality of the image seen. So the question is, how do we examine a person's eye? And you've seen this anatomical cross section of the eye already, with the retina being the focus here. That's the area of the eye that I focus on. And when we take photographs of the eye, this is what it looks like inside a normal eye. So taking a photograph through the cornea, through the lens, and looking at the retina in the back of the eye. And what we see in this picture are the optic nerve. This is the optic nerve here that connects the eye to the brain. And all this orange stuff is really the transparent retina. There are blood vessels that we can see on the surface of the retina, and much more subtle blood vessels underneath the retina that look kind of like very faint tiger stripes behind the retina here. The retina itself is transparent. And of course, we have the fovea in the very center here. This is the central part of the vision, the macula, with the fovea in the center, and then the peripheral vision over here. And so this is zooming in, so you can see this really nice high quality field of view. And I've already outlined the macula and the peripheral retina already. So when we think about the layers of the retina and how this multi-layer structure can convert light into a neurochemical signal, we can kind of look at the cross section of the back of the eye, this is the inside of the eye, this is outside and behind the eye, and there's the retina is the orange. Then there's the foundation of the retina in green, and then there's a blood supply underneath the retina. That's that tiger stripe pattern that I was alluding to previously. And when we see patients in clinic, every patient that I see in clinic gets a photograph that looks like this. And you can see how it's amazing that we can see this layered cake of retina. Again, this is inside the eye, this is behind the eye, and this is the cross section of the spongy-like blood flow underneath the retina. Um, and then, of course, this is over here is the optic nerve connecting all the information that comes from the retina to go back to the brain. And when we think of a healthy eye versus an eye with advanced macular degeneration with geographic atrophy, you can see this cartoon structure here, where we have the layers of the retina shown here with the foundation of the retina over here. That's what we're seeing in this little black box on the healthy retina. And then in advanced macular degeneration, we can see the death of these layers of cells, the retinal pigment epithelium and the photoreceptors. And this is one of the most intensely metabolically active tissues in the body. They're constantly consuming energy to sustain vision. And you can see structurally how the retina changes when someone has macular degeneration as opposed to when they don't. And even on the color photographs, you can see the change in the quality of the retina. So when we think about age-related macular degeneration, we think of dry macular degeneration or wet macular degeneration. I kind of give this analogy because the foundation of the retina, the retinal pigment epithelium, that is responsible for sustaining the energy consumption and production of critical molecules in turning light into neurochemical signals. The foundation is affected severely, and this is kind of a picture of a sinkhole where the foundation of a house is damaged and the overlying structure is compromised, and this is a picture of a flood where the foundation of the house is damaged further, and then the overlying house is also damaged. So really what we focus on is foundation maintenance, trying to make sure that the foundation is not allowed to propagate to more cracks and breaks, and that it is sustained. So when we think about any disease, disease starts with an early stage and then it progresses to more advanced stages. And so this is an early stage picture of macular degeneration. You might be able to appreciate these little yellow spots in the retina, and these are called small drusen. Drusen is a German word for bump. And these are accumulations of waste material underneath the retina. And as the condition progresses, we get more and larger drusen that can accumulate. And just to remind you what the normal retina looks like, here's the cross-sectional picture that we obtain in clinic called the optical coherence tomography, the OCT image. And here's what those bumps can look like. You get lots of bumps underneath the retina that are the lipoproteinaceous accumulation of byproducts. It's basically the garbage not being taken out. And so this accumulation of waste products from normal vision um, causes damage to the cells around it. And as macular degeneration progresses, it can result in wet macular degeneration. And this is where there are new blood vessels that grow underneath the retina to try and compensate for these waste products accumulating and the reduced flow of normal flow of blood to the retina. So in this picture, we can see patches of blood underneath the retina. And if we look at the cross-sectional view of the retina, we can see that there's fluid accumulation in the retina, there's elevation of the foundation of the retina, and there can sometimes be small pockets of fluid underneath the retina as well. And this is a disruption of the sensor in your camera, the film in your camera. And you can imagine that if you made a distortion to the film in the camera, it wouldn't be able to take a very high quality image. In terms of advanced dry macular degeneration, you've already seen a picture of this, and we've seen that how there is actually a loss of the cells in the foundation. You can see this nice thick layer of foundation over here, this bright white line, and then that becomes a little bit undulating and bumpy, and then there's a complete absence of that line over here. In fact, we see the bedrock, we call it the Brooks membrane underneath the retina, and then the photoreceptors that are on top of the foundation, those uh, those die as well, and that results in permanent vision loss. So, how do we counsel patients when they're not in clinic to monitor their condition? Well, I like to tell patients to look at blinds or at a door frame because they're very straight lines and right angles, and it's easy to look at one quickly. But the gold standard is this kind of graph paper where we have somebody looking at the black center over here. They're not moving their focus. They're keeping their eye on this little black dot in the
Maybe
center,
there'll be a fish
and they
tomorrow.
observe with their peripheral vision the
No,
other
I'm
part.
listening to the video.
I think we may have somebody who has unmuted their
Oh, I'm
camera.
sorry. I didn't know you were
Or,
there.
yeah,
Thank you for bringing it up.
thanks.
I thought,
Actually, I'll go ahead and mute you. Apologies for that. So what a person will do is stare at the black spot and they'll observe the peripheral lines with their peripheral vision. They won't directly look at all the different lines. They'll keep their vision fixed over here, and they'll check maybe once every 2 weeks to see if there's a change. Is there a part of their visual field that becomes absent, becomes brighter, becomes distorted? And that's a way of screening for a change in one's vision. And so that someone might see something like this, or they might see an area that becomes grayer, or they might have a complete absence of vision in one part, and these various forms of distortion. Another way of monitoring for distortion that really hasn't picked up extensively, but basically is a home test where people are instructed to look at a center dot and to observe a line as it moves through the vision, and they have to see if there are portions of that line are not straight. And then the system would alert their healthcare provider if that there's a change, and might ask the patient to come in sooner to be evaluated. But I haven't seen this being widely adopted. Another technology that's being developed and has shown promise are these home-based OCT systems, basically a very sophisticated laser scanning system that one has in one's home. Um, and basically they screen for these pockets of fluid underneath the retina, and you can see that there's a comparable appearance to what we might see in a clinical image. And these systems are being built around artificial intelligence to screen for subtle changes. But I don't actually know any patients who'd had these at home yet, and this is a system that is being developed further for at-home screening. But you can imagine this is a non-trivial technology, and being able to supply them to the anticipated 288 million people worldwide by the year 2040. It would be hard to have that many of these type of systems at home, let alone a million or even 500,000 of them. So, moving on beyond what one can do to monitor disease at home, one really is the goals is prevention. And in this box, I have the modifiable risk factors for macular degeneration, and the most important one is cigarette smoking. Um, it's not as much of an issue on the West Coast in California where we are, but I did a significant portion of my training in Ohio where the amount of tobacco use is much higher. But this is definitively the highest risk factor for accelerating progression of macular degeneration. So always encourage people who are tobacco users and smokers to at least know how many cigarettes they're smoking on a daily basis and try and reduce it by one cigarette per month to minimize the risk of progression. High blood pressure, which is HTN is how we abbreviate it in medicine, and hyperlipidemia, high cholesterol, these are more loosely affiliated risk factors, and we try to encourage people to modify these as well. And also, if they have any heart disease, cholesterol buildup or high blood pressure. So really, stopping these things that are bad for the brain and the heart are equally important and critical to modifying the risk of progression to advanced macular degeneration. Things that are unmodifiable are things like family history. My dad had macular degeneration. I have a high risk of having macular degeneration as well. Having a certain prescription error, light or blonde colored irises like blue and green irises, and being female. That doesn't mean that men aren't at high risk of it, but if you're blonde hair, blue eyed, you have a higher risk. And that doesn't mean that if you're from, Africa or East Asia or South Asia or South America, that you're not at risk for it as well. And I have plenty of patients from those demographics who also have macular degeneration. Then, of course, the Mediterranean diet is really critical. So I tell my patients to imagine they live in Santorini and maximize their servings of whole grains and nuts, lots of fruits and vegetables, in particular green leafy vegetables, things like kale and spinach, and having a lot of foods with omega-3 oils, really fish with omega-3 oils. So these are salmon is the highest content, tuna, lobster, shrimp, sea bass, sardines, anchovies, trout. All of these are really good sources of omega-3. And this was shown in the AREDS, the age-related eye disease studies, to slow progression. This was a NIH-sponsored longitudinal clinical trial that occurred in the 1990s that lasted for about a decade that looked at the rate of progression in people with all stages of macular degeneration, with early, intermediate, or advanced. And it showed that that modifying one's diet um, could reduce the risk of progression to advanced macular degeneration with vision loss. And then, of course, with therapy, there are injections and lasers, and I'll talk some more about that later. Lasers have really fallen away. That was the way things were done up until the 90s and maybe mid-aughts. But really, very few patients are getting any kind of light-based therapy in the form of lasers. Injections have really become the mainstay of therapy for advanced macular degeneration. I'll talk about that some more. But let's just give you an idea of the amount of time that was invested by our tax-paying dollars um, to understand how we can modify the risk of progression in macular degeneration. In the 1990s and early 2000s, it was the age-related eye disease study, and then the AREDS 2 study began in the aughts and extended to the 20 teens. And one of the fundamental contributions and critical to all patients with intermediate or beyond macular degeneration was the discovery that these vitamin and nutritional supplement cocktails slowed down the progression of the disease. In the first AREDS formulation, vitamin A was included in addition to vitamin C and E, zinc and copper. But it was found that patients who had a history of smoking and taking this high dose of vitamin A had a higher risk of developing lung cancer. So we completely migrated away from vitamin A to trying to find alternatives. And so the AREDS 2 study found that a similar cadre of nutritional supplements to vitamin C, E, zinc, and copper were beneficial, but in addition to adding lutein and zeaxanthin, as well as this omega-3 supplementation. So this is what all patients are recommended nowadays because you just don't have to worry about whether someone was a smoker or non-smoker because vitamin A has been taken out of the formulation. And I mentioned already before that the AREDS 2 study really solidified that consuming fish, in addition to whole grains, nuts, and green leafy vegetables, but really I focus on fish because not everybody likes fish. And the fish provide omega-3 oils that are critical to slowing down the rate of progression. And unfortunately, things that are not fish, which means omega-3 pills, are not helpful in macular degeneration, and uh, plant-based omega-3s are not helpful or have not been shown to be as helpful. So, really encouraging patients to take omega-3 in the form of fish 2 or 3 times a week at least. So I encourage patients to, bake a salmon one day, have a can of tuna the other day, and have some sushi another day. Just really try to have as much omega-3 as possible, and doing so safely. Of course, if you're having a lot of mercury in the fish, then you have to think about monitoring which specific types of fish you're consuming that might have higher mercury content. So I wouldn't recommend people having tuna and salmon every single day of the week, but mix it up with other forms, other fish that don't have as high mercury content, and certainly lobster and shrimp count for as an omega-3 source. Um, so I kind of harp on on this Mediterranean diet because it's really the opposite of what we do in the Western diet, and that is we have lots of desserts and sweets and processed meats and red meats, so highly processed foods, and this is just the worst thing for macular degeneration and really for heart health. So it's really turning upside down our Western diet in favor of the things that are in the bottom here, which is fruits and veggies, whole grains, green leafy vegetables, and fish. So we think about how can we slow down the rate of progression and how do we treat people with macular degeneration? Well, we have seen that with the AREDS vitamins, that there is a benefit for people with intermediate and beyond macular degeneration. However, there has not been shown to be any benefit in early macular degeneration or in people that are healthy or who might have a family history of macular degeneration. Now, I have a family history of macular degeneration, and the way that I modify my risk is with the tried and true therapy for all medical maladies, and that is diet and exercise. So I don't take the AREDS vitamins. Again, my dad had macular degeneration. I'm, Caucasian male. I have a great family history of unlikelihood of having it, but I don't take the AREDS vitamins. I do consume as much fish as I can. My kids do too. And I do have lots of green leafy vegetables. And I try to exercise whenever possible as well. So diet and exercise reduces risk of heart attack and stroke, and really is critical to macular degeneration progression because it's not when someone turns 70 and they're diagnosed with macular degeneration that they have developed it. They've been developing it for 70 years. And so really having the decades of preparation and risk reduction is critical. And that goes for smoking as well. Fortunately, smoking is not as big of a epidemic as it used to be, but it still is endemic in many areas. So just to clarify, benefit for intermediate or beyond macular degeneration, take the AREDS vitamins. And then, of course, Mediterranean diet always. So when someone does progress to wet macular degeneration, they're developing new blood vessels that break through the foundation underneath the retina, and they can leak and they can bleed. And that's why we can see bleeding in this color picture over here. And we can see pockets of fluid underneath the retina. And so the mainstay for the last 20 years or so, but really popularized in the last 20 years, are these injections of anti-VEGF medications. And what these medications are, is they are something that stops new blood vessels from growing. And they take new blood vessels that have grown and that are not really high quality blood vessels. They're always a little bit leaky, and they make them a little bit more mature so they stop leaking as much. So to try and when someone comes in with acute vision loss and they have maybe some blood on their retina or they have some fluid underneath the retina, we give an injection of an anti-VEGF, anti-vascular endothelial growth factor medication. And that takes these blood vessels and makes them try to behave like more normal blood vessels. And then the retina actually visibly improves. And the patient's vision also can notably improve significantly. In other words, the FDA requires have 3 lines of improvement on the visual acuity chart. That's 15 letters that one would read. And so this began in the I think late 1990s with Macugen, which I think is still available. It's not really injected anymore, but all these other brand name drugs, in addition to something called Avastin, which is not indicated for use in the eye, but it is the most broadly used anti-VEGF in the world, even in the eye. It's actually a cancer medicine. These are injected into the eye to try and rehabilitate vision in someone with wet macular degeneration. But more than rehabilitate, to try and maintain low activity of new blood vessel leaking or growth. And so trying to sustain vision long term. Now, even when we start to treat people with who have wet macular degeneration, it doesn't mean that the disease stops. It just controls one of the complications of advanced macular degeneration, the new blood vessels growing. The condition unfortunately does tend to progress even slowly over time, even if the wet macular degeneration is controlled. So, we still recommend, the nutritional supplements and diet. So when someone has injections in the eye, we kind of grade the number of injections based on their activity of the disease. So someone with a high activity or a poor response to medication might get an injection every month for 8 or 9 months, and then they might be able to space out their injections over time. Someone with medium activity might require a couple injections initially, and then they can start to space out their injections a little bit sooner. And someone with a more high responsive um, form of macular degeneration in its wet form might be able to space out immediately. So, and everybody's a little bit different. So we typically think of someone who's going to be a low responder being a third of P patients, a medium responder another third of patients, and a high responder another third of patients. And we can't predict that, at least at this point. Artificial intelligence, I think, will make it possible for us to make predictions um, in the future, but nothing has been made clinically available for making that kind of prediction and prognostication to advise patients. One of the more recent versions of the therapy is this port delivery system. It's basically a little capsule that is surgically implanted into the eye, and it makes a little reservoir where one can inject this anti-VEGF medication into the eye, and it's released over about a 6 month period. And every 6 months, the port is refilled. And that's the goal there is, again, of course, trying to sustain low activity of the disease for an extended period without having to come in for an injection every month, possibly. Um, I'm going to go back over here. Another variant that's being investigated are similar types of injections, but with newer mechanisms of action. And some of the ones that you might see in some press releases are things called tyrosine kinase inhibitors. And so those have shown some promise. We may be seeing our first line of tyrosine kinase inhibitors being introduced to the market in the next couple of years. Another form of therapy that is being investigated and has shown some promise are gene therapy based injections. So basically, it's a similar idea where you inject something into the eye. I'll come back to this picture because it doesn't have to have a port or a reservoir, but you just inject this viral load or maybe a non-viral gene delivery platform that takes some DNA and it enters into the cells inside the eye, and it convinces those cells inside the eye to start to produce the same medication that we would be injecting otherwise. So basically, turn the eye into a bioreactor or a factory to make the medication itself. And in doing so, reduce the number of injections that are needed. There's some very promising results that are emerging, and it might makes the people with high disease activity, it might mean that they only have to have 2 or 3 injections in a year, whereas a low activity patient might need to have no injections in a year after this new viral or non-viral gene therapy based approach. And so that seems quite promising for reducing the burden of having patients come in for frequent injections. So in terms of dry macular degeneration, where the foundation cracks and breaks, but there's not necessarily new blood vessels that grow, we think of these dark patches that we can see in these black and white images. These are glow in the dark images that show us healthy and gray versus unhealthy areas of the retina in black. And so a couple of years ago now, a family of complement inhibitor drugs were FDA approved. And the goal of these complement inhibitors is that you can see that these areas of black over time increase in size. So these complement inhibitor drugs try to slow down the rate of these black areas of cell death to try and preserve vision. And the trouble with this family of medications is they don't make vision better necessarily. Their goal is really to slow down the rate of vision loss because all of these areas that are dark are where there's little to no remaining vision. And so when these areas expand and consume the central vision, over time, then central acuity is lost. So someone might be 20/20, 20/20, and 20/20 even in this third picture, and then go to not only being able to see fingers held up in front of their eyes to count the number of fingers. But with these injections, they've been shown to slow down the rate of this progression and hopefully give someone meaningful central vision for a longer period of time. But it's really tough because patients with this condition have to come in every 4 to 8 weeks. I have my patients come in every 6 weeks for an injection to slow down the rate of progression. And there's no way that we can counsel someone that we can't quantify how much benefit they're gaining from it. We can just say that from the clinical trials in hundreds of patients, these medications have been shown to slow down the rate of progression in this condition of geographic atrophy in macular degeneration. But it at least gives us something that we can use at this point. Um, my colleagues at UCI do use this therapy to slow down the rate of progression. We don't do it in every single person who has geographic atrophy. It's a conversation with the patient so that they understand, the burden of coming in and not necessarily seeing a benefit. But for someone who has central vision that remains and the atrophy is close by, we will offer it. And even if the atrophy is not necessarily close yet to the central vision, we will offer it as well to try and preserve the vision as long as possible. Um, there's a newer therapy that has the same goal as these injections, and that's something called photobiomodulation, which is designed around having patients come in for, I think, 9 sessions um, over a few weeks of staring into light of specific wavelengths, and then they repeat that a few months, like maybe 9 or 10 months later. Um, the data has not been yet necessarily as convincing to myself and my colleagues yet, although we remain optimistic that this might be an additional avenue for offering light-based therapy to patients. But this would require patients coming in and staring into this device for a fixed period of time, every several times over a few weeks, and then maybe a few months later repeating the same dosing protocol. And this may slow down the rate of progression in patients, but at this point, my colleagues and I we're just waiting for the rigor of the data to become a little more convincing before we start providing this as an option. So what I really urge to any patient is that when people come in and they're diagnosed with macular degeneration is don't lose hope because there are many ways that one can sustain one's vision, and we are living in this time of innovation, which is very exciting.
Thank you, Dr. Browne.
Yeah, thank you,
Have a
everybody.
good night, everyone.